Good morning, good afternoon, good evening to folks in the US, in Pakistan. I know there's several of you joining from Pakistan and other places. Uh, Today is the session 9 of COVID Dialogue. And as you know, COVID is a truly global challenge. It has been a great equalizer. You know, we have all socioeconomic condition, all types of people, all types of houses from pink and red and white houses got infected. Unfortunately, I was checking the numbers today. Millions of people are getting infected every day. Right now, total confirmed cases is 4.1 million globally. US, unfortunately, is top of the list. And luckily, in many developing countries, low resource countries, the numbers are not as high, but there is a concern that things will go up with time. As you know, the purpose of our session is to have a dialogue, a true dialogue between global North and global South. And the purpose is to learn from each other. None of us know really how to do it well. We are all learning as it's coming through. These sessions are organized in collaboration between Center of Excellence on Trauma and Emergencies at Aga Khan University and the Center for Global Emergency Care at Johns Hopkins. This collaboration has been supported for a long time by the NIH and Fogarty. So we are really happy to have all of you here. Today's session, as you know, is about caring for critically ill patients in the emergency department. And I have two wonderful panelists who will take us through how they are managing issues at their own hospitals. And then we'll open it up for discussion and questions from the audience. So I'd like to first introduce, and then I'll have my colleagues maybe add a few more things. Daniel Scott Swedien. He is a colleague of mine, an instructor in emergency medicine at Aga Khan, at the Johns Hopkins University Hospital. And the other person, Dan, a couple of more things. Dan did residency at Johns Hopkins, a wonderful colleague. And the reason I asked him to join us is because he's been working with a large group of people on coming up with clinical guidelines on managing these patients in the emergency department. So welcome, Dan. The other person I have is Dr. Hamid. Hamid is leading emergency department at a hospital called Lady Reading Hospital in Peshawar. And I have had the occasion of visiting that place a few times, and it has evolved under Hamid's leadership. And I know how challenging it is to work in some of these situations. So Hamid, welcome, and we'd love to hear from you guys about your experiences.
Thank you, Jimmy.
So let me start by asking Dan to share a few slides and sort of structure our discussion for today, and then we'll come to Hamid, you to share how what Dan is talking about fits into your environment. So Dan, over to you.
Okay. Thank you for that introduction. One of the things is, I will try to keep the chat window up here. Can you see the PowerPoint, everyone?
Yep.
Okay. First off, one of the things I wanted to focus about is some of the critical care in COVID. And with our limited time frame, we couldn't obviously cover everything that happens with the critical care of a patient coming in who is COVID positive or assumed to be COVID. One of the things I wanted to talk about is some of the key decisions that we'll make. As Dr. Razak outlined, we have a large, what we call clinical affairs team, where it's an administration team of doctors trying to make guidelines for how to do this in our own department. And so I wanted to share some of those things here. At any point, another thing too is in the text box or afterwards, feel free to drop a message of what you're interested in learning, because then we can shift gears a little bit and focus more time on that, because I know time will be a little limited. One of the things that I think is most important is that you should attempt to make every important decision before it happens. And that is one of the reasons why, and Dr. Zak, is the slides moving along? Quick question.
Yes, they are. Just make sure that you do the slide show button.
Got it. Okay. One of the things is that I think every important decision should happen, or at least attempt to happen, before it actually happens. So I wanted to run through some of the quick overall important decisions. And before we get into the actual, some of the medical management things is, and this is going to quickly outline it, is before we get into the medical management and the critical care and the oxygenation and support, is actually talk about patient flow. Because I think that's one of the actually most interesting, challenging issues of this topic. One of the things that I think, I guess in this limited time frame, in the 60 to 90 days that we've known about this and really been dealing with in the US, is we've had to change how we see patients. Before this, we would see anyone, anywhere, anytime. But COVID has kind of changed that current approach, because as we know, if patients are positive or suspected positive, have a high rate of infecting other people. So I think one of the key decisions in actually critical care is how and where you're going to do the critical care. We are blessed to be at a research-rich institution. So this may not apply everywhere, but have to try as best we can to adapt whatever you can from this. So the way our institution has done it, and is doing it right now, is that we actually have like a split flow model, where we maximize the areas that we have that are the most protected, being that our rooms with the most negative pressure or the most HEPA filters would be preset to contain the suspected COVID patients. And that seems obvious at onset, but what is new is that we're having to change the staffing models to appropriately fit that. Secondly, is that we have noticed, and I'm running the data right now, is that at many of our institutions, we have 5 institutions in our system, is that we're in a new interesting problem with COVID, is that one day we will have, well, for us, is a very high number of COVID positive or suspected COVID patients. And the next day we'll have almost none, but we'll have critical cares of our, what we call our old variety. And then the next day it'll go right back to having a high number of COVID positive. And it creates an interesting challenge for treating critically ill patients, is that you have to quickly be able to swing resources and protection. The way we designed it to do that, and would be interesting for someone else to attempt, is that we had swing areas. And Dr. Zak knows about this from my almost daily emails of who's going where, but is to have, and it's all on a spectrum, from the areas that you know are best handled to take COVID patients, and you fill them first preferentially up with suspected patients. But you got to have a little area in between that can treat non-critically ill patients, that can go between being COVID patients and non-COVID patients. And lastly, you have to do the same thing for critical care. You have to be ready to handle all patients that come in that are critically ill, either COVID positive or suspected, and COVID negative. And lastly, on that topic, is at our institution, we've chosen to that every patient that comes in would be considered to be COVID positive if they're critically ill and cannot give us a history. So that's one thing just kind of on the onset for how we wanted to handle the flow of critically ill patients. In just a brief minute now, we can talk about what I think are some of the biggest branch points in critically ill patients and the actual care of them. Again, these are, as I was talking with Dr. Zak in the past couple of days, just to kind of highlight some of the points where your team might switch the most and change their care the most. And these are strategies that will have to be tailored to whatever resources are at any institution. Is kind of the strategies of how you're going to deal with the mid-level respiratory support. So for patients who are coming in who need oxygen, but don't necessarily need to get intubated. And that would be with high flow nasal cannula and BiPAP. A quick overview of that, I know we're limited for a little time, is that high flow nasal cannula, and I'll pause here, I think we have a chat. Okay, we'll go back to that. Is high flow nasal cannula has been shown to have less aerosolizing effect than BiPAP. And so we are preferentially using that for people who need additional respiratory support. Now, there has been a lot of foam med and other online resources about proning patients who have a need for increased respiratory support. I think one of the biggest and most important things on this topic is to actually decide when and who you're going to prone, and actually look at the literature before you do it, because there's a very limited number of studies to talk about this. And so I think for people in that mid-range who otherwise look well, high flow nasal cannula might be a nice support. But I would not do that for anyone in respiratory distress. And secondly, we are still not doing BiPAP or external means of non-invasive pressure ventilation at our site. But that's also on a spectrum too. I think that your administrators and your team needs to be on a spectrum of, if there's no ventilators in your institution, you might need to temporize people with BiPAP. You need to have that conversation before it happens. So right now, we're not currently using BiPAP, but that's something that can be available at your institution. A little bit of background on both of these for high flow nasal cannula and BiPAP is that in ARDS patients, which COVID has some overlap in, they're actually not shown to stave off intubation. So we've seen some anecdotal evidence that high flow nasal cannula in our COVID patients does, but to date for ARDS patients, we have not shown that either of these strategies prevent intubation. So then kind of on to the next thing you want to think about is for cardiac arrest and intubation strategies of how you're going to do it. I think briefly, one of the things that's most important for intubation is the protection of yourself. If you can, to maximize the amount of protection, and this kind of goes for all care of all patients, is to make sure that you have the appropriate personal protective equipment, be it an N95 respirator and a face shield or a PAPR device, and preferentially in a negative pressure room. Now that is obviously a higher resource setting, and you'll have to tailor that to wherever you are at for your institution. I think one of the big things is for cardiac arrest, and one of the new guidelines is that the new AHA guidelines set it up pretty well on how you want to run a cardiac arrest, and this just came out on April 7th, I believe. Specifically that you should try to minimize the amount of time that you spend bagging a patient. And so when a patient comes in cardiac arrest, via externally or is already in-house, is to actually apply a non-rebreather face mask to them and then quickly intubate them as fast as you can to avoid bagging them and aerosolizing things in the room. They actually go so far as to say that while you're intubating, you should stop doing compressions. That at our own institution was met with a lot of pause and concern. So there's no clear consensus at our institution on that topic, but it is one thing to consider. As far as intubation strategies, I think one of the things is that it is very important to, if you can, maximize the first pass success using GlideScope or whatever the provider feels most comfortable with, so that they minimize the time in the airway for their own personal safety. And lastly, I think if we've talked about kind of for critical care, the big things are making your decision about high flow nasal cannula and BiPAP, cardiac arrest for getting them intubated as quick as you can. Also on cardiac arrest, if you have it available, use an external piston device such as a Lucas machine. I would also too, for the resuscitation, there's been a lot of foam med and various other things to talk about decreasing the amount of fluids that you give these patients, but I would really warn that all those trials are after the first 24 hours. So I actually treat these patients just like I would any other septic patient at the onset. And our actual critical care doctors have come down and said that we've actually under resuscitated a little. They've needed to give more fluids and hemodynamic support upstairs because of that. So those are the big things on that topic. And lastly, just in the quick, very quick 10-minute overview of critical care, we've talked about using BiPAP and high flow nasal cannula in the intermediate patients. In cardiac arrest, the principles are is to try to use an external device and intubate as quick as possible. And lastly, one of the things is what vent settings I think are most important. And that would be using the ARDS settings either at low or high PEEP. And you can find these just on the ARDSnet network card just on their website. And I think if you get people on those at the onset, that's where we'd sit. And from an administrator perspective, I think the other things in critical care you really want to take the time to think about is what your critically ill patients normally come in as and how you're going to handle the workflow. We've already seen just numerous, this problem with like transport, moving people, getting the pictures you need because everyone's worried about keeping everyone safe, which is the right thing to do. We're really fleshing these workflows out ahead of time is going to save you a lot of grief afterwards. So I'll wrap up there. I know I had about 10 minutes to talk, and I think I'm right on there. And that's kind of what I wanted to just mention is what I think are the big points, which is identify your flow beforehand, identify your critically ill patient pathways, kind of the three things on critical care that I think are most important to kind of convey. So with that, if you have any questions about anything, please let me know.
Thanks, Dan. And before I move to Hamid, can you I don't know if you remember how many patients are currently at Hopkins and what's the distribution in terms of ICU versus non-ICU? Do you have any sense?
I do. It's skewed a little bit because we're transferring in patients from our system at Hopkins. Let me stop sharing here because I have it on my computer. And so what was your initial question?
So I was asking you if you know the number of cases that Johns Hopkins Hospital has taken care of so far or are in the care at this time, and how many of them are critically ill?
I would have to pull that up. It would take me a few minutes.
Yeah, sure.
I can pull up how many have come through the ED and tested positive.
Sure. So while you're looking for it, let me go to Hamid. And Hamid, the question to you was, how are you managing your critically ill patient in the resources you have? And what you heard from Dan, how is that different from your practices?
Thank you, Jeanette. Now, let me just give you a bit of perspective about the Lady Reading Hospital. It's one of the biggest hospital of KP, and basically when all this COVID-19 crisis started, the government health department decided that this particular hospital will act as the HDU and ICU for the rest of the KP, apart from like the rest of the couple of tertiary hospital supports. So the main thing was, as Dan nicely mentioned, that the first thing that we were concerned about was the patient flow. And as we all know, that it's very difficult to set up a public sector hospital in Pakistan for a reasonable, good patient flow. So we prepared beforehand, and the main thing was that we have to have a very proactive triage. And we do have like a normal triaging within the emergency department, but for this response, we had to take it outside, and we did it right in front of the main emergency gate. We improvised with like big tents and stuff like that. We divided into 3 stations. So in the first station, it was just a temperature check and a couple of questions. If they were on that initial assessment, they were suspected, then they had to go to station 2, where there was a case definition by the doctors and nurses. And station 3 was for regular emergency patient triaging. Now, initially we started with this practice, but then what should happen with the patient once they are inside the emergency department? How can we proactively segregate them or flag them up? So we came up with a model of a screening model, like the one with the respiratory symptoms are really unwell patient. We have to have a screening area. So all of them went into that. And we have to have a chest x-ray, a CBC for them within half an hour. And what I noticed that like in most of the suspected patients, we did have chest x-ray findings like infiltrates, either unilateral or bilateral. And that really helped us to segregate the patient. And to let you know, as Dan mentioned, that like within the resources, what we did that we segregated the emergency department into safe and unsafe zone within the available resources. So the screening area was in unsafe zone. And once the patients been screened and they were safe to be transferred for active emergency management for other causes. And the College of Emergency Medicine, Royal College of Emergency Medicine has published recently a flag as well that like we shouldn't be forgetting about the rest of the emergency patients as well. So the screening area act as sieving the safe and unsafe patient for us, and that's why it made it easier for us to look after the other emergencies as well, like DKAs and MIs and stuff like that coming through. From triage, we have directly referred around about 140 patients to high dependency unit, and to ICU 38 patients. And these are from that screening area and triage that we referred. And then we have got casualty medical wards, like emergency medical wards, like male and female, and there are referrals from that area as well. The problem down here is that like there is no actual GP services. So we end up having our a casual outpatient running as well as emergency service. But this time we've been very strict about that, and we have clearly told everyone. So we've been deflecting people from triage as well. So that's kind of a small model of the patient flow. When it comes down to the resuscitation or initial management, obviously it's been evolving situation. We've been learning throughout as well, and we've been in touch with our colleagues abroad as well as the colleagues inside Pakistan. And as it's mentioned down there as well in the previous presentation by Dan, very nicely, that like the safest route was high flow nasal cannula. And in some instances, we used non-rebreathe masks as well in a very low saturation patients or peri-arrest patients. We have set some triggers for the patients to stay in emergency department. So for the flow was that like if anyone having high flow nasal oxygen and their saturations are going and less than 92, so for the time limits for that was within 1 hour, they should be shifted to ICU. And for that purpose, we have got an airway team based within the emergency department who used to be in their proper PPEs, and they used to either intubate or shift the patient to ICU and intubate time there. And for the rest of the patient, they will be shifted in 2 hours to HDU. So these kind of challenges that we came across, and all this has to happen in the last 8 weeks. Initially, it was a bit shabby to start with, but like slowly and gradually, we work together. Now there is the HDU, the high dependency unit is run by what we call a CRT team, a corona response team, which is a mix-up of a general physician and pulmonologist. And the ICU is actually run by the intensivist and anesthetist, and they team up together to run that. So, so the whole model is triage, screening area, the rest of the emergency department, and then HDU and ICU. The ICU settings and the vent and everything, that has been with close collaboration with our colleagues from ICU colleagues from intensivists from United States as well as UK, and we share information. And there has been a lot of changes in the practice as we go along, and we are learning as we go. Thank you.
Great. Dan, you want to say a few words about the capacity? Yeah, numbers?
Yeah, so right now at Hopkins, we've tested positive over, I think, 1,500 patients. As far as our overall capacity, we've been running pretty well, knock on wood, and we still have more ventilator space at Hopkins. And that specifically, some of our numbers have been kind of flatlined since our state governor has put in a mandate that we have to stay at home and socially isolate. And so right now we have in the range of about 50% capacity, it looks like. And most of these patients we are actually able to discharge. And we've admitted about 500 through the ER. And secondly, to your point, Dr. Hamid, I agree. We run actually almost an exactly same split flow model where we have a triage person in the middle right away, and it kind of puts them down 2 different pathways. So it's very similar to everything we're doing here. The only thing that I would maybe sounds different is that when our critically ill patients come in, we kind of, just because we know that they're, we're worried that they're sick, we triage them afterwards, and we just take care of them in the first place. And if they look critically ill at the onset, we just treat them as positive. So probably more get lumped into the, COVID person under investigation label that don't need it, but it's kind of what we do, but very, very similar.
Great, thank you guys. I have a question from one of the participants, Salman Arif, and maybe both of you can answer. I think that the answers will vary a little bit. So the question is about a patient who comes in with shortness of breath, and you're not sure whether it is ARDS due to COVID or just congestive heart failure. In that setting, the person is asking, BNP is not available. Can you still differentiate or not? And my question will be, even if you have BNP available, can you really differentiate between COVID and non-COVID? So Hamid, maybe I can have you give first response to this in your setting, and then maybe Dan, you can also chime in.
Sorry, Junaid, I didn't get the question.
Yeah, the question is about how readily we can differentiate between ARDS due to COVID and acute pulmonary edema in the ED, so that we can place the patient at right place earlier. And they're asking, doing a BNP or pro-BNP is not an option here in LRH-ER.
That's it's a very tricky one, but once you start seeing so many X-rays of COVID ARDS, it's make it very easy for you to differentiate, start differentiating between the ARDS as well as even the initial ARDS picture, as well as the pulmonary edema that you're dealing with. There are other signs that we also take in consideration, like obviously we look into the cardiomegaly, we look into the upper lobe diversions and stuff like that, which really makes it easy for us. And the person, in some instances, the history and the ECG also help as well. But my opinion is that the more you see these X-rays, the more it gets made easy for you to understand that, like, well, what should be the differentiating points.
Dan, what's your practice?
Well, you know, I get to cheat a little bit because I can get more information, but I, you know, in addition to everything that was just said, which I completely agree with, is that I have the benefit of having an ultrasound machine, and that you can help characterize if it's pulmonary edema, see the squeeze of the heart, you know, to kind of make that tiebreaker, whether you think it's pulmonary edema from a CHF pattern or more of a ARDS pattern on the other hand. And then lastly is I know some people are getting actually CAT scans if they're really, really ill. So those are the things that typically fall into my wheelhouse, but the safest one would be ultrasound for me, and that's how I help differentiate. So if that's available where you are, that's what I help use as the tiebreaker.
Would you, and maybe asking both of you, would you admit a patient with shortness of breath, cardiomegaly on chest X-ray, and you don't have a test back on COVID? Would you admit them to a non-COVID floor, Dan, and then maybe Hamid?
I wouldn't take that chance anyway. In this practice, the best thing is, the safest practice is that, like, if the patient is unwell or like any shortness of breath, which you haven't got a clear diagnosis or clear COVID testing, the best thing is, or the safest thing is, to admit in the COVID complex, do your investigation, give him supportive treatment, give him the right treatment, and then take it from there.
Yeah, I think one of the things that our institutions, and I think across the board, are dealing with now is, should their test results also come back first before they go upstairs? That is, you know, I heard the volume you're running through, Dr. Hamid, that would create a lot of problems for you, I imagine, as it might create here too. I would admit them to the area that I had the most clinical suspicion for. Erring on the side of caution, and if I had any tiebreakers, more towards them being COVID positive.
There's a question around the use of steroids, and it's with you, Dan. What are the recommendations using steroids at Johns Hopkins?
Right now, we are not using steroids for patients unless they have a significant other underlying medical reason why they would need that. Or, and the second one that comes back most common is actually, now I forget the trial, whether it was the corticus, andromedia, which one. If they have persistent vasopressor requirements, we give them hydrocortisone. If they have an underlying obstructive physiology and COPD, and it sounds like that, we might give them steroids based on that, but not right now for COVID just on its own.
Hamid, you want to add something?
We don't do steroid therapy apart from just the obvious, like if there is a wheeze and then we are very confirm about it that it's due to the bronchospasm, yes, we would give it, but otherwise we don't use steroids in that. Thank you.
How much do you rely on a chest X-ray, a positive chest X-ray and a negative chest X-ray?
Well, reliance is it's not like a gold standard or gold practice that we should do, but it guides us in a way. The other thing is that you can be, it can be a bit deceiving to rely initially on a very clear X-ray. But you have to take everything in consideration together, the history, the examination, the clinical acumen of the patient at that particular time. But as long as what I've noticed here in KP, I must share that the COVID-19 has been stigmatic down here. The people or the patient don't present in the early part of the illness. And when they do, they're really unwell. And the X-rays that I've seen has got a lot of them, most of them has got established changes.
And I want to add one thing to that is what it makes it clinically interesting and difficult is that I've seen a lot of the worried well come in, and I've seen a lot of the people who actually otherwise look okay and get a chest X-ray, and then there's already changes. So I completely agree with your point. You have to add it into everything that you're seeing. It's hard to rely on it either way. Sometimes I've seen X-rays that look terrible and a patient otherwise looks well, and I've seen just the opposite. So I think you have to take the full picture together because you can get fooled and misled either way. Maybe in the future we'll find that early chest X-ray changes are predictive for something or something, but I don't. To my knowledge, we're not there. I've been doing a lot of reading on this, and as of like a week ago when I last updated, I didn't see any early signs yet.
Good. How about the reliance on oxygen saturation? At what point, do you have a number where you decide to intubate?
Yes, we made it because it was very difficult for us to decide, and the huge amount of people coming in and patients and like what should be it. So basically, we decided that like anyone who has got like a saturation above 96% on room air, they should be the ones who we can isolate them, either home isolation or observation isolation. The next batch was the unwell patient. So in unwell patient, we were dropping the saturations, and with high flow nasal cannula or high flow nasal non-rebreathe mask, if they were not maintaining the saturation above 92%, then we were involving ICU. Otherwise, we were keeping those patients in HDU. So our cutoff was and is 92, less than 92.
What about you, Dan?
Similar. It sounds like you're using kind of an escalating pathway. We do somewhat similar, room air, nasal cannula, high flow nasal cannula. At high flow nasal cannula, we left it at 90. There are some people who want to early prone those patients. I'm not fully in support of that because I think if a patient's really decompensating, there's not actually studies to support that. I think it's good for the people potentially who are just on a nasal cannula. But for people who are failing high flow nasal cannula, I don't prone them, and at 90 is kind of a recommendation because normally that means in the acute setting, they've already developed such a requirement that I think that their trajectory is likely that they would need to get intubated. And if their stats are in the 80s on high flow nasal cannula, we intubate them. One thing we do is we keep the flow at 40 liters, and we can turn up the oxygen in the mixer to 100%. But we keep the flow at 40 instead of sometimes you can go up to 60. Because I can send this out afterwards when I refind it. I don't know where this comes from right now. But once you get so high of a flow, then you start to aerosolize. So that's one thing that we do with the high flow nasal cannula. But in the 80s, we intubate.
Yeah, and there's a lot of discussion and debate on when to intubate. I remember when we first started talking about this disease, we said, intubate early. And then there were some people were saying, maybe intubation early is not helping patients and maybe you should give a little more time. And numbers, saturation numbers are being tolerated to a level where we would not normally. You understand?
Yeah, I do want to make a comment on that. I think two things on that. One is you have to take a look at where your institution is. If you have no more ventilators yet or are nearing that, I think you have to change your paradigm a little bit about what you're doing. At the onset, and I think actually where we are right now, where we still have capacity, you can, keep with your current trend. Whether CPAP, BiPAP, or other things will be needed if we have no more ventilators, that's a great question, and that'll have to be reevaluated at that time. Second point is I think, Dr. Zak, what you're talking about is that people who otherwise look well with an oxygen requirement. I haven't seen them yet. I haven't seen anyone who looks that well failing high flow nasal cannula. I've seen the pictures out there. I just personally have not encountered them. And I think if I had a person failing high flow nasal cannula in our current ED situation, I think that they should still probably be intubated. I know that some people are like the people who look well, and some people advocate proning that patient. I think it'd be, because we have the intensivist space right now, I'd opt to have them go there. Because as you know, we can easily get pulled away, and to me it's a patient safety concern that if I get pulled away or another one of my team members gets pulled away and we can't have one-on-one observation of them, that makes it a very dangerous situation.
Good, and I want to now bring a couple of, there are a number of questions around what other things we can do. So antibiotics, thinking about pneumonia, overlying pneumonia, or actual pneumonia, and we are just waiting for diagnosis of COVID. The question around antivirals, are you guys thinking about or using any of those? Remdesivir, everybody's talking about, hydroxychloroquine, and finally, there's a lot of discussion around heparin. So Dan, you want to take this first, and then Hamid?
I think one of the things about antibiotics is we are using them because in the early situation where you don't have all the information back, a certain number of these just turn out to be community-acquired pneumonia, and you wait for an 8-hour test come back, or however long your test comes back, and you haven't been treated with antibiotics. I think you do a disservice. So I think it's reasonable to give them antibiotics and treat for pneumonia. I secondly think that as far as anticoagulating them, it's reasonable based on the patient. If you happen to have got a D-dimer or other studies, they're not going to be moving for a little bit, is to give them some therapeutic, subtherapeutic, preventative or prophylactic if you're going to admit them, some DVT prophylaxis. I don't think we've come to a consensus on any outpatient anticoagulation, but definitely for inpatient, prophylactic dosing for patients is something that's considered on a patient-by-patient basis. The hydroxychloroquine, that was initially had a kind of a phase where it was being considered used a lot. We're getting that less and less. And the other new one, we're starting to take a look at now and see how we can put that into effect. In our emergency room, because we still have capacity, we are delaying that decision to start that drug right away until we get all the information back and we really know where we're going.
Great. Hamid?
So we are using the antibiotics, as Dan said. Intubating them, yes, and it goes through ICU treatment.
You're cutting off a little bit, Hamid. Can't hear you very well.
Right. Can you hear me now?
Yes.
Yeah. So we've been giving antibiotics, and we've been using anticoagulation for them as well. The thing is, initially when we started the HCQ, there was a little bit of evidence. Now there's obviously the same practice is going on still in our ICUs as well, that they've been giving HCQ. I'm not sure about any evidence that we have got resting behind it at the moment. So that's the practice going on at the moment.
Okay. How about, there's a question around the GI symptoms, diarrhea. A patient comes in only with diarrhea. Are you suspecting them to have COVID?
Go ahead, Ahmed. Sorry.
Right. It's very difficult. It's very difficult that just with the diarrhea, and especially when we are talking about like in Pakistan setting, when as soon as the sun is a bit hot and you end up having half of the emergency department is full of gastroenteritis and stuff like that. So yes, we have got the list of the symptoms that we look into. One of that is obviously gastrointestinal system symptoms, but we have to take like the contact, the fever, and the symptoms in consideration as well. Because at the moment, if I just segregate the list of the patient presenting with the gastrointestinal system to emergency department, they might reach like at least a couple of hundred a day. So that will make very difficult for us.
You mentioned a point about you have to put it in context, and I think my context is just almost, it's in a different area where we see less patients with gastroenteritis. We of course see a fair number of them, but actually I've had a couple of my first positive patients were with purely GI symptoms, and they were a patient with no other reason to have gastrointestinal symptoms coming in with them. And so you kind of, at the time we did the test and I had a lower suspicion, it came back positive. So I've had patients with it, and the patient I'd be worried about it, and to your point to who to test, is those without other clear explanation of why they would have gastrointestinal symptoms. If they're not in there's just was mentioned that it is a high prevalence. If it's not a high prevalence, if they don't have any predisposing condition, I think you definitely have to consider it, because I've personally seen positive patients in that scenario.
The whole concept of patient or person under investigation, when you're not sure, we have so many of these patients where we are not sure, we put them in this basket called PUIs, and then we test them and come to a decision. But of course, when you have 200 patients coming in with diarrhea a day, it gets a very different decision. I want to come to a more complex, I guess, decision, which hopefully, luckily in the US, we have not had to make, and I'm not sure about Peshawar, or in the US means where we work at Hopkins. It's about rationing ventilators. And if we ever come to that point, especially in a context of Pakistan, but also we heard from New York and Italy, do you have any sense of direction? Do you have any guidance from your institutions on how do you make that decision? Dan, why don't you go first, and then Hamid?
Yeah. So I mentioned on my second slide is those decisions are best made before they happen. We are lucky at our institution that we were proactive in that. So for every critical resource, such as ventilators, ECMO, blood transfusions, a large committee of people was put together. I was on the ECMO one, along with some of the other people from our department, and every department was represented to make the parameters that if we had to start rationing, how we would do it. The second is that the governor of our state, I don't know what the final verdict was, but someone had actually polled the residents of Maryland years prior to get their information on what they would want in a crisis like this. And so we have some idea of what our local residents would want and how they would want us to handle it. We're using that in combination with a panel to give a recommendation to our governor. I haven't heard the outcome of that, but that's how we're handling it. Because knock on wood, we don't get there. But it is something you have to think about.
So in your case, in our case, the government is going to be deciding for sort of policy level who would get and who would not.
Yeah, I think and don't quote me on this, I was not part of this at all. I think the idea is that a group of physicians at the large centers in our state realized that we had a pretty good idea of what our citizens wanted based on papers that came out of I think it was out of our own emergency room. And so they wanted to set the tone and kind of go to the government first with their proposal. I think that was their idea, is to that they worried that the proposal would otherwise come from someone who might not be as informed as they thought they were. But I was not involved in that one in any way. I think that's second and third hand information.
Great, thanks. Hamid?
Well, we've been lucky that we've got a huge hospital, around about 2,200 beds that we have got, and we have spared a whole block, which used to be a cardiology block for COVID patients, and we've got a 140-bedded HDU and a 38-bedded ICU. Up till now, we are not struggling with the ventilators at this particular time, but we have had a few discussions about it, that what will happen. Now, I don't know why, but like the patients and the relatives down here are not very keen on going onto ventilator. That's one of the things which is coming across. Maybe due to COVID and the initial information that there's some misinformation to the families, and they're very concerned about their patient going onto the ventilators. The other thing is that at the moment we are good, but we have had discussions, and it comes across that we need to look into that, whether we should be setting that the mortality that we have got in either the age group or the comorbidities, then we should think about who should we prioritize. It might not be at all our decision. It will be a discussion which is going on at the moment as well in the Department of Health. They're very reluctant to come up with a decision because, as you know, in Pakistan, everything is political, and they don't want to label any that these kind of patients will not be offered ventilators. And they're still coming up with a slogan that they will be provided with ventilators. Everyone will be. But one day there will be a reality check. There will be ventilators which will be needed, and we have to make a decision. So I think if the government might not be able to come up with that decision, then the MTI LRH have a plan, and they will come up and step in at that particular time.
Good. One last question, I think, and then we will. There are lots of questions around, treatment, and you addressed some of this. And somebody asked about multivitamins and vitamin C and those kinds of things and their role in the care. I know in some countries there's the practice of using those a lot as something people believe in. They actually go to the hospital to get vitamins. What's the practice in your setting? Why don't we start with Hamid and you'll go to Dan?
Well, there was a initial a huge thing about vitamin C and supplements, and straight away it was off the market. None of the shops had it. But as far as like the literature and everything is concerned, we've got enough in our system to boost up the immunity. And if we are immunosuppressant, I don't think so that like, and the evidence suggests that like it can't be just boosted in a days or so with vitamin C or a zinc supplement. So that is my take on it. I would love to hear from Dan what he thinks about that.
I think I heard you say that we probably have enough vitamins in us, that adding a single daily dose isn't going to add much. Did I hear that right?
What was that?
I couldn't hear you fully, but I think
like
the
people are talking about like boosting their immune system by having zinc supplements and stuff like that. Like I don't think so that like we can boost the immune system in an active illness like COVID with the vitamin supplements. And I just wanted to hear from you. What is your take on that?
Yeah, I think when our friend gets done, with the Victus trial, which is one of the ongoing trials for this, we'll have more information. But right now, especially in America, I don't think that adding vitamins to a group of people who's probably already saturated with vitamins is going to be of much benefit right now. That may change when that information, and I'll eat my words, when some of our friends' trials come out in the Victus trial about vitamin C in sepsis. So that's something to definitely reconsider when it comes. But right now, I would not. I don't think that it adds to the treatment plan right now, or at least I don't know of any data that it does.
Let me ask you one question from my side to both of you. If you had to change one or two things in your ED or what's available to you, what would those changes be to improve the outcome of patients with COVID? Or to actually, let me just say, or to address this pandemic, not just the outcome of individual patient, but generally for the pandemic. What changes would you make?
Well, for me, I think so. LRH emergency department has seen quite a lot of mass casualties in terms of military insurgencies, and they used to be like huge numbers of patients coming to the emergency department, but it used to settle down, and we do have plans for like mass casualties, but we never had plans for pandemics and stuff. We never had a society of emergency medicine sitting and talking about or coming up with the plans for like pandemics and stuff. So this particular COVID-19, if I learned something from it, there's a huge need of preparation for pandemics like this. And obviously, I know this is not good that the whole world is in pandemic and COVID-19 is taking over, but it has taught us a lot as well. Like I'm happy that my colleagues know how to wash their hands properly now. What is PPE? What is the role of N95? What are the hand sterilization techniques and stuff like that? So I think so preparation and having the minimum required stuff present in the department in a pandemic store, I would suggest. Thank you.
Thanks.
You know, it's a great question. I think I kind of have an answer at three levels. Or one is, one thing I'd like to change is it would, I think, add a lot to the treatment of the disease in the course if we could test everyone. Then the second thing is I think before we do that, we need to come up with an answer for how we're going to treat people who have immunity and who don't. So I think it could definitely snowball into a situation where, people might be ostracized if they haven't had the disease or not. So we need to think about that before it happens. The time is now, probably. And then lastly is I'll echo what was just said, is when we see all these people come together, that's the one thing that kind of makes it easier to get up and go to work and help on things like this, is that we see what we can do when we all put our heads together. And now, I was just talking with one of our other colleagues, Dr. Irvin. It'll be interesting to see what secondary effects this has, and remind ourselves that when we all get together, we can really make some positive things happen. And when this is hopefully, we can start working on them together. And even now, it's things like violence and, social injustice, inequalities, and all those things. I think it'll be really interesting to learn from this and see that when we all get together, we can have a positive impact.
Great. Thank you both for really engaging conversation and answering these somewhat complex and vague questions in such a nice way. My last announcement is for the next week. A couple of things came up, and I want to address that. A week from now, we're going to be talking about stigma, fear, and dead on arrival in the times of COVID. And we will have two great panelists, Dr. Simi Jamali from JPMC Jinnah Hospital in Karachi, and Lee Wallace. Lee Wallace is from South Africa, a real global mover and shaker in global emergency care. And we look forward to seeing you guys there and have a discussion on this whole issue of stigma and fear. Thanks everybody for joining us, and we'll see you next week.
Thank you. Thank you, Janet.
Thanks.